The 20 most dangerous anesthesia mistakes. The 20 most dangerous anesthesia mistakes. Recognizing, preventing, and managing the errors that cause the most harm. Anesthesia is safe, but not forgiving. In anesthesia, there is no small mistake. A small error can cost a life within minutes. Every day, we hold a patient's life between consciousness and unconsciousness, between breathing and apnea, between life and death. That privilege demands absolute precision. The most dangerous mistakes in anesthesia do not always come from knowledge. They come from assumption, haste, poor communication, failure to check, and failure to prepare. A wrong drug, a missed allergy, an unrecognized difficult airway, an unchecked machine, inadequate fasting, poor monitoring, hypotension ignored, hypoxia missed. These are not just errors. They are preventable catastrophes. This presentation is not to frighten us, but to wake us up. We will dissect the 20 most dangerous mistakes that have harmed patients and ended careers. We will learn how to recognize them early, prevent completely, and manage them decisively when they occur. Because in anesthesia, our best is not enough. Perfection is the standard. Preparation is the lifeline. Vigilance is the price of safety. Let us learn, unlearn, and relearn, for the sake of the patient who trusts us with their life. Topic: The 20 most dangerous anesthesia mistakes. Theme: recognizing, preventing, and managing the errors that cause the most harm. Anesthesia errors are rare but can cause rapid and irreversible harm. This lecture focuses on the most critical mistakes to improve recognition, strengthen prevention through checklists and vigilance, and ensure timely management to reduce morbidity and mortality. Clinical Patient Safety Lecture. Agenda. 5 categories, 20 mistakes, 1 goal, 0 preventable harm. Category 1. Pre-anesthesia and equipment failures. Includes inadequate assessment, missed allergies and comorbidities, and failure to check machine and emergency equipment. Most preventable harm starts before induction. Good preparation prevents intraoperative crises. Category 2. Drug and medication errors. Includes syringe swaps, wrong dose, labeling errors, and unsafe use of high-risk drugs. Anesthetists handle potent drugs with narrow therapeutic index. A small error can cause immediate life-threatening effects. Category 3. Airway and ventilation failures. Includes failure to anticipate difficult airway, inadequate airway strategy, and failure to oxygenate and ventilate. Airway is the first priority. Failure to oxygenate is the fastest cause of brain injury and death in anesthesia. Category 4. Monitoring and vigilance lapses. Includes ignoring alarms, inadequate monitoring, failure to recognize hypotension, hypia, and malignant hyperthermia. Continuous vigilance and early alarm response allow detection of deterioration before irreversible harm. Category 5. Crisis recognition and systems failures. Includes poor communication, lack of teamwork, failure to call for, and poor documentation and handover. Technical skill alone is insufficient. Human factors and system safety determine outcome during crises. Category 1 of 5. Pre-anesthesia and equipment failures. This category covers errors that occur before induction, including inadequate patient assessment, missed history, and failure to check the anesthesia machine and emergency equipment. Errors at this stage are the foundation of most intraoperative catastrophes, and thorough preparation is the key to prevention. Mistake 1. Skipping the pre-anesthesia machine checkout. What goes wrong? Anesthesia machines, vaporizers, ventilators and gas supplies are assumed ready without a documented pre-use check. Leaks, empty cylinders, misfilled vaporizers, or a disconnected oxygen supply go undetected until induction. Clinical consequence. Hypoxic gas delivery, awareness from an empty vaporizer, barotrauma from a stuck valve, or total loss of ventilation at the most vulnerable moment, which is induction. Prevention best practice. Perform a full machine checkout, self-test, breathing circuit leak test, backup O2 cylinder confirmed, suction tested, before every case, not just the first of the day. Use a standardized checklist, e.g. FDA, ASA pre-use checkout. Clinic URL. The machine that worked on the last patient is not guaranteed to work on this one. Circuits get swapped, vaporizers get topped up incorrectly, and cylinders run empty between cases. Mistake 2. Failure to anticipate a difficult airway. What goes wrong? Airway assessment, malpractice, thyromental distance, neck mobility, mouth opening, prior anesthesia records, is rushed or skipped, so a difficult airway is discovered only after induction and paralysis, when options are limited. Clinical consequence. Can't intubate, can't ventilate scenario, hypoxic brain injury, emergency surgical airway performed under pressure. Prevention best practice. Systematic airway exam on every patient, review of prior anesthetic records, and an explicit difficult airway plan, awake fiber optic, videolaryngoscope on standby, surgical airway kit opened, whenever risk factors are present. Clinical Pearl. If in doubt, secure the airway awake. Awake intubation is never a failure, an unplanned surgical airway is. Mistake 3. Incomplete history, missed allergies and drug interactions. What goes wrong? Time pressure leads to a cursory history, missing prior anaphylaxis, malignant hyperthermia, family history, anticoagulant use, or MAUI and other interacting medications. Clinical consequence. Anaphylaxis to a previously reacted drug, MH triggered in a susceptible patient, bleeding from unheld anticoagulants, or dangerous drug interactions, e.g. serotonin syndrome. Prevention best practice. A structured anesthetic questionnaire covering allergies, family anesthesia history, current medications and supplements, cross-check against the planned drug list before induction. Clinical Pearl. Ask, has anyone in your family had a problem with anesthesia? It is the single highest yield MH screen question and is frequently omitted. Mistake 4. No immediately available backup airway equipment. What goes wrong? Difficult airway trolley, videolaryngoscope, or surgical airway kit is stored elsewhere in the department rather than in the room, costing critical minutes during a crisis. Clinical consequence. Prolonged hypoxia while equipment is fetched during a CICV event. Minutes matter and irreversible injury begins around 4 to 6 minutes of hypoxia. Prevention best practice. A dedicated, checked difficult airway trolley in or immediately adjacent to every anesthetizing location, with contents verified on a fixed schedule. Clinical Pearl. Rehearse the call for help pathway. Who comes, how fast, as deliberately as you rehearse the drugs. Crises are won or lost on system response time. Category 2 of 5. Drug and medication errors. This category focuses on mistakes in drug preparation, labeling, dosing, and administration. Anesthesia involves many high-risk drugs given rapidly under pressure, and a small syringe swap or dilution error can become life-threatening, so strict labeling and double-checking are essential. Mistake 5. Syringe swap. Wrong drug administered. What goes wrong? Unlabeled or similarly sized colored syringes are drawn up in advance and administered by look-alike confusion. Classic pairs: vicuronium, neostigmine, ephedrine, local anesthetic, insulinheparin. Clinical consequence. Awareness under paralysis if a paralytic is given instead of an induction agent, arrhythmia, or fatal drug effect. Prevention best practice. Label every syringe at the moment it is drawn up. Use color-coded labels per class of drug, perform an independent double check for high alert drugs, and read the label aloud before injecting. Clinical Pearl. The few seconds it takes to label a syringe are the cheapest insurance in the operating room. Mistake 6. Overdose from miscalculation or concentration confusion. What goes wrong? Weight-based dosing errors, especially in pediatrics, decimal point mistakes, or confusing mg with milligram per kilogram, or a 1% vs 10% concentration same drug. Clinical consequence. Local anesthetic or opioid overdose, cardiovascular collapse, respiratory arrest. Prevention best practice. Standardized dosing references, apps for pediatric and high-risk drugs, a second clinician verifying weight-based calculations, and standard drug concentrations stocked in the unit to reduce mental math under pressure. Clinical Pearl. Any dose calculation that is 10x higher or lower than expected should trigger an automatic recheck before administration. The decimal point is anesthesia's most dangerous character. Mistake 7. Unrecognized local anesthetic systemic toxicity last. What goes wrong? Inadvertent intravascular injection during regional blocks, or exceeding maximum safe local anesthetic dose, with early signs, perioral tingling, tinnitus, metalliced, dismissed as anxiety. Clinical consequence. Seizures, cardiac arrhythmia, and cardiovascular collapse that can be refractory to standard resuscitation. Prevention best practice. Calculate and respect maximum weight-based doses, aspirate before injection, inject incrementally, and have 20% lipid emulsion immediately available wherever regional blocks are performed. Clinical Pearl. Know your lipid emulsion protocol before you need it. Last cardiac arrest requires prolonged CPR plus lipid rescue, not quick round of epinephrine. Mistake 8. Rescue and antidote drugs not immediately available. What goes wrong? Dantrolene for MH, Sigamidex neostigmine for residual block, lipid emulsion for last, or naloxone flumazenil are stored far from the point of care or in insufficient quantity. Clinical consequence. Delayed treatment of a rapidly progressing crisis. MH mortality rises sharply with treatment delay, while staff search for antidotes. Prevention best practice. Stock rescue medications in every operating suite per departmental protocol. Check expiry and quantity on a fixed audit schedule, and run periodic crisis drills, e.g. simulated MH event to rehearse retrieval. Clinical Pearl. A malignant hyperthermia cart that takes 5 minutes to find has already cost the patient 5 minutes of untreated hypermetabolism. Category 3 of 5. Airway and ventilation failures. This category covers errors in airway assessment, management, and ventilation. The airway is the anesthetist's primary responsibility, and failure to secure it or to recognize failed ventilation leads to hypoxic injury within minutes, which is why structured assessment and backup planning are non-negotiable. Mistake 9. Unrecognized esophageal intubation. What goes wrong? The endotracheal tube is placed in the esophagus, and this is not confirmed, refuted objectively before proceeding. Relying on auscultation or chest rise alone, both can be misleading. Clinical consequence. Rapid, silent hypoxia progressing to cardiac arrest and hypoxic brain injury, one of the most preventable causes of anesthesia death. Prevention best practice. Continuous waveform capnography is the mandatory standard for confirming and continuously monitor tracheal tube placement, not just a single colorimetric change. Clinical Pearl. No capnography trace, no tube in the trachea until proven otherwise. Treat a flat capnograph as esophageal intubation until you have actively ruled it out. Mistake 10. Can't intubate, can't ventilate, CICV, not managed algorithmically. What goes wrong? Repeated intubation attempts continue past the point of diminishing returns, oxygen saturation is allowed to fall without declaring the emergency and escalating, and a rescue plan, supraglottic airway, surgical airway, is not activated early enough. Clinical consequence. Hypoxic brain injury or death from a situation that is survivable if escalated promptly. Prevention best practice. Follow a recognized difficult airway algorithm, e.g. ASA per decasecond. Limit intubation attempts, commonly 2 to 3 before escalating. Declare the emergency out loud, and move to a supraglottic airway or front of neck access without delay once the algorithm dictates it. Clinical pearl. The failure is really the difficult airway itself, it is the delay in escalating to the next step of the algorithm. Mistake 11. Extubation with residual neuromuscular blockade. What goes wrong? Reversal is given empirically without objective confirmation. Quantitative neuromuscular monitoring, e.g. train of 4 ratio is greater than or equal to 0.9, or timing is misjudged relative to the last dose of muscle relaxant. Clinical consequence. Post-extubation upper airway obstruction, hypoxia, aspiration, and reintubation. Residual paralysis is one of the most common preventable postoperative respiratory events. Prevent best practice. Quantitative neuromuscular monitoring on every patient receiving a non-depolarizing relaxant, and objective confirmation of adequate reversal before extubation, using Sagamedex where appropriate for faster, more reliable reversal. Clinical pearl. A patient who can lift their head for 5 seconds is reassuring but not a substitute for a measured train of 4 ratio. Mistake 12. Aspiration from inadequate NPO status or missed rapid sequence induction. What goes wrong? Fasting status is not verified, or a patient with aspiration risk factors, full stomach, pregnancy, bowel obstruction, obesity, reflux, is induced with a standard technique instead of rapid sequence induction with cricoid pressure and immediate airway control. Clinical consequence. Pulmonary aspiration of gastric contents, aspiration pneumonitis, ARDS, prolonged ICU stay. Prevention best practice. Confirm NPO status explicitly, identify aspiration risk patients preoperatively, and use rapid sequence induction with a pre-oxygenated, head-up position and immediate cuffed tube placement when indicated. Clinical pearl. When aspiration risk is uncertain, treat the patient as a full stomach. The cost of an unnecessary RSI is trivial compared to the cost of aspiration. Category 4 of 5. Monitoring and vigilance lapses. This category covers failures in continuous monitoring and situational awareness during anesthesia. Most critical incidents evolve silently, with subtle changes in capnography, oxygenation, or hemodynamics that are only caught if monitoring is active and interpreted. A lapse in vigilance turns a detectable drift into a crisis, which is why disciplined monitor watching and alarm management are central to safe anesthesia. Mistake 13. Ignoring or disabling capnography alarms. What goes wrong? Capnography alarms are silenced or turned down due to alarm fatigue, or the monitor is positioned out of the anesthetist's direct line of sight during a busy case. Clinical consequence. Delayed recognition of disconnection, esophageal intubation, or airway obstruction, the same catastrophic pathway as mistake number 9, caused by inattention rather than absence of the monitor. Prevention best practice. Keep capnography and pulse oximetry in continuous view. Avoid muting alarms without an active plan to address the cause, and treat any alarm as real until proven otherwise. Clinical pearl. An alarm you have gotten used to ignoring is an alarm that is no longer protecting your patient. Mistake 14. Unnoticed breathing circuit disconnection or malfunction. What goes wrong? A circuit disconnects, a valve sticks, or tubing is kinked, and this goes unnoticed because vigilance has lapsed or the monitor display is not being actively watched. Clinical consequence. Silent hypoxia and hypercapnia, potentially progressing to cardiac arrest before anyone notices. Prevention best practice. Continuous, active monitoring of capnography, oxygen saturation and airway pressures, not passive presence of the monitor, and low-pressure disconnect alarms enabled and audible at all times. Clinical Pearl. Monitors do not prevent harm, someone actually watching them does. Mistake 15. Inadequate depth of anesthesia leading to intraoperative awareness. What goes wrong? Anesthetic agents are underdosed relative to surgical stimulus, common with total intravenous anesthesia (TIVA) without processed EEG monitoring, neuromuscular blockade masking cues, or a deliberate, light, technique in hemodynamically unstable patients without compensating with amnesic agents. Clinical consequence. Explicit intraoperative awareness with recall, a source of severe and lasting psychological trauma, PTSD-like symptoms. Prevention best practice. Use processed EEG depth of anesthesia monitoring for TIVA and high-risk cases. Ensure adequate anesthetic delivery is confirmed, not just assumed, especially when muscle relaxants are used, and have a low threshold to supplement amnesia in hemodynamic unstable patients rather than simply lightening anesthesia. Clinical Pearl. Paralysis without adequate anesthesia is the classic setup for awareness. The patient cannot move to signal distress. Mistake 16. Fatigue, distraction, and loss of situational awareness. What goes wrong? Long shifts, multitasking, charting, phone use, conversations unrelated to the case, and production pressure erode vigilance during the routine maintenance of anesthesia, when most critical incidents actually occur. Clinical consequence. Delayed detection of any of the above events. Fatigue and distraction are consistently found as contributing factors across closed claims analyses of anesthesia mishaps. Prevention best practice. Sterile cockpit discipline during critical phases, induction, emergence, crisis management, fatigue risk management, adequate breaks, shift limits, and a culture where a distracted provider can be relieved without stigma. Clinical Pearl. Most anesthesia disasters happen during the dramatic moments but during the quiet, routine middle of a case when attention drifts. Category 5 of 5. Crisis recognition and systems failures. This category covers the failure to recognize and respond effectively when a crisis is unfolding, and the breakdown of system-level safeguards. It includes delayed decision-making, poor teamwork and communication, lack of access to emergency protocols or equipment. Errors here are less about a single technical skill and more about how individuals and teams function under pressure, which is why this category is often the final common pathway to harm. Mistake 17. Delayed recognition of intraoperative anaphylaxis. What goes wrong? Early signs: hypotension, tachycardia, bronchospasm, rash under drapes, are attributed to anesthetic depth, blood loss, or surgical manipulation rather than an allergic reaction, especially since urticaria may be hidden under surgical drapes. Clinical consequence. Delayed epinephrine administration, refractory cardiovascular collapse, and death. Anaphylaxis mortality is closely tied to time to epinephrine. Prevention best practice. Maintain a high index of suspicion for unexplained hypotension, bronchospasm after any drug or product exposure, antibiotics, neuromuscular blockers, chlorhexidine, latex, and give epinephrine early and empirically rather than waiting for a full diagnostic picture. Clinical Pearl. Treat first, confirm later. Tryptase levels and allergy testing are for tomorrow, epinephrine is for now. Mistake 18. Malignant hyperthermia not recognized or treated promptly. What goes wrong? Early signs: unexplained rising end-tidal CO2, tachycardia, masseter spasm, rising temperature, are misattributed to light anesthesia or inadequate ventilation rather than triggering MH protocol. Clinical consequence: rhabdomyolysis, hyperkalemia, cardiac arrest, DIC, and death if dantrolene is not given promptly. Mortality rises steeply with treatment delay. Prevention best practice: know the early signs cold, stop all triggering agents immediately on suspicion, call for the MH cart and extra hands early, and administer dantrolene without waiting for confirmatory testing. Clinical pearl: rising end tidal CO2 that does not fit the clinical picture as malignant hyperthermia until proven otherwise. Mistake 19. Mismanaged hemorrhage and hypotension. What goes wrong? Blood loss is underestimated, especially with drapes, suction obscuring true volume, or hypotension is treated repeatedly with vasopressor boluses without addressing the underlying volume, surgical source. Clinical consequence: progression to hemorrhagic shock, coagulopathy, and cardiac arrest, particularly dangerous when it develops insidiously rather than as a single dramatic bleed. Prevention best practice: track cumulative blood loss actively, wade sponges, suction canisters, communicate closely with the surgical team, activate a massive transfusion protocol early rather than late, and treat persistent hypotension as hypovolemic until excluded. Clinical pearl: if you are chasing blood pressure with repeated vasopressor boluses without asking, why is it low, you are treating the number, not the patient. Mistake 20. Wrong site, wrong patient, or wrong procedure, surgery from a skipped timeout. What goes wrong? The pre-induction, pre-incision surgical safety checklist and timeout are rushed, performed from memory, or skipped under time pressure, allowing patient identity, procedure, site, or consent mismatches to go undetected. Clinical consequence: irreversible harm from an entirely preventable systems failure. Anesthesia is administered to, or surgery proceeds on, the wrong patient or site. Prevention best practice: treat the WHO surgical safety checklist and formal timeout as non-negotiable for every case, actively participate rather than passively agree, and empower every team member to stop the process if something does not match. Clinical pearl: the timeout is not a bureaucratic formality, it is the last barrier between a checklist error and an irreversible mistake on the wrong patient. The 4 recurring root causes. Across these 20 mistakes, 4 recurring root causes emerge. 1. Skipped or rushed safety checks under time pressure. 2. Failure to use or trust objective monitoring, capnography, neuromuscular monitoring, depth of anesthesia. 3. Delayed recognition, escalation of evolving crises. And 4. Systems and communication failures rather than isolated individual error. 1. Skipped or rushed checks. Checklists, timeouts and pre-use verification bypassed under time pressure. 2. Distrust of objective monitoring. Capnography, neuromuscular monitoring and depth of anesthesia data ignored or unused. 3. Delayed crisis recognition. Early warning signs misattributed instead of triggering escalation protocols. 4. Systems and communication failures. Harm traced to team, equipment access and process gaps, not isolated individual error. The bottom line: vigilance, standardized checklists, objective monitoring, and a low threshold to call for help are the common threads that prevent nearly all of these mistakes from becoming patient harm. Patient safety in anesthesia does not depend on avoiding one big error, but on building layered defense against small, recurring failures. When we stay vigilant, use checklists consistently, trust our monitors, and call for help early, we break the chain before harm reaches the patient. Thank you for watching. If you liked this content, don't forget to like to show your support, comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.